Good morning, and thanks for joining us today. My name is Diane Mihalik. I am the Chief Marketing and Corporate Communications Officer for Munson Healthcare. Joining me today are three clinical experts from Munson Healthcare, and you'll first be hearing from Dr. Christine Nefsey, Munson Healthcare's Chief Medical Officer. You'll also be hearing from Dr. Mark Cannon, infectious disease expert with Munson Healthcare, and Dr. Nick Torney, infectious disease pharmacist with Munson Healthcare. They will begin by making some statements, and then we will move into the Q&A session. So it's my pleasure to introduce Dr. Christine Nefsey.
Thanks, Diane, and good morning, everyone. Thank you for joining us. We're going to start with just an overview of the data as we have in the past. We are continuing to see good news in Northern Michigan as far as our rate of increase. So you can see here cumulatively we're at over 20,000 cases and at 425 deaths. If you look down at our cases per 100,000, for the last few weeks we've seen a decline in both the number and our percent positive. We have, for the last 3 days or so, seen a leveling off. So we're not seeing further decline, but we're not seeing an increase either. So we continue to follow it and are encouraged by the fact that we're not seeing it go back up again. Go ahead, next slide. You can see here the reflection of our total inpatients. So again, certainly more than we saw in the spring, but that 46 is significantly less than we were seeing last month or so. So we continue to have positive inpatients, but a manageable number and no huge increases again. Next slide. You can see here our trend up, kind of leveled off there, is slowly trickling down, and now again for the last few days has kind of leveled off. So something that we continue to monitor and hope will continue to decline. Next slide. I wanted to bring this to people's attention. You know, we hear a lot of, this is just a normal flu, these numbers are inflated, that kind of thing. This is a graph from the CDC and MMWR, and this really looks all the way back to 2017, our general seasonal fluctuations of what we see for basically influenza-like illness. And so if you look at those yellow bumps there at the bottom, that's typically what we see for flu. And this double line that goes up and down in that wave form, that's really what we call our epidemic threshold. So when you see that red line there that typically follows that, that's really the number of deaths due to pneumonia, influenza, and now COVID. So you can see here starting in 2019, really a huge increase in the number of those deaths. And these are not only the number of deaths that are coded as COVID-19, but also influenza-like or pneumonia-like illnesses. So, you know, when we talk about the vaccine and why it's important to get the vaccine, as well as why it's important to continue to socially distance and wear masks, this is really from the clinical perspective why we are trying to make that argument. Next slide. So we reported last week that we'd received vaccine. These are our current totals for vaccine that has been given. We did also start this morning to start the second dose for some of our employees. So again, we continue to be very, very excited about our opportunity here. Next slide. And so that's a 5,371 total as of yesterday evening that have received their vaccine. That's approximately just over 50% of our eligible employees and credentialed providers that have been vaccinated and or scheduled. Next slide. So again, to reiterate, you know, the distribution of this vaccine, we are following the CDC as well as the state health department's guidelines, and we are currently in Tier 1A. Tier 1A is all of our healthcare personnel and long-term care residents. We are opened up to all people that meet that definition and are making plans and setting up the infrastructure to be able to move to the Tier 1B in the near future. We don't have dates yet on that, but we are starting to make the plans with our health department on how we will do that in each of our communities. Next slide. We would ask that you be patient. What we did with Tier 1A is, announce and send information out to people when they were eligible so that they could start to schedule. We will do the same as we move to Tier 1B. One of our limiting factors is knowing when we will get vaccine and how much vaccine we will get. The state has been doing a really remarkable job of working with us and communicating with us. They are limited as the vaccine is distributed at a federal level, understanding for the state how much vaccine they will receive as well. So we are trying very hard to be as transparent as possible with when we are receiving vaccine and how much, and we'll continue to do so. Next slide.
Thank you, Dr. Nefsi. Appreciate the opening remarks. And now I'd like to introduce Dr. Mark Cannon, who's the infectious disease expert with Munson Healthcare. Dr. Cannon, we have been receiving a lot of questions related to how the vaccine works and what is contained in it. Can you give us an overview of what the vaccine is?
Sure. So I'll start by just sort of describing what a vaccine is supposed to do, and I'll concentrate on, I'll use the word virus a lot because that's what we're talking about, but vaccines do apply to bacterial infections and other things as well. But the idea of a vaccine is that it's a gentle introduction to your immune system, so of an infectious agent, of a virus, so that if you do encounter that virus in your day-to-day life, your immune system will already be primed to quickly and robustly shut down any infection. So traditionally vaccines, and vaccines have arguably, they're arguably in the top 2 or 3 most important achievements of humankind. I mean, their effect cannot be overestimated on the health and benefit to humankind. And they all typical routine vaccines are insanely safe as well. So they come in various flavors. Vaccines are, viral vaccines can be a killed virus. So a virus that's been inactivated, say by heat, but it still expresses all these viral proteins, which triggers our immune system to make a robust response. So if we get exposed, boom, we're ready to go and shut down a true infection. Vaccines can be a live virus that's been sort of gutted, so that although it's still technically live, is to the extent that viruses are alive, that's arguable, but that it's been gutted so it's unable to cause a productive infection, unable to make you sick, or if it does make you sick, it'd be incredibly mild disease compared to the real thing. And then again, lots of viral proteins being expressed so that our immune system can attack that. There are some vaccines that are simply a protein. The protein is introduced directly, our immune system sees that protein, makes antibody. RNA vaccines or DNA vaccines will concentrate on RNA, but what I'm saying kind of applies to both. These are nucleic acids. That's been proposed 30 years ago. It was an obvious thing to think about. The idea there is that the vaccine would consist of RNA, which is a blueprint for proteins, and our cells would take up that RNA and then make that viral protein, and then our immune systems would react to that protein and make antibodies and memory immunity and such. So it's been studied. This is not a new thing. This has been studied for literally decades in academia and other places. The reason that we have finally crossed that finish line and have a commercially available one is not so much that this was some new technology, but it was more the political and public will and the funding necessary, the guarantees to the companies who needed to sort of do the final touches and do the clinical studies, that they wouldn't be left holding a big bill and that they would, make the money they need to make to survive. That's why this all happened so quickly, not because somebody just came up with the idea a year ago and rushed it through. There's a great, for anybody who needs it, I have a great link to a review of this and how this came to be done in such a short time, in the background to nucleic acid vaccines from a article in journal Nature. So I'm happy to share that with anybody. It's a great review. But do not think that this was somehow, rushed through. This has been a technology that's been a long time coming. It's finally here. It's going to have a lot of implications for not only infections, but also cancers, potentially autoimmune disease. It's absolutely, I think it's really game changing. It's very, very exciting. So nice things about RNA vaccines. They cause a robust response because you're having your own cells make that protein, which gets all the legs of the immune system, all the arms of the immune system involved. So that we get a nice, robust, coordinated response if we do get exposed to the virus. They're also very safe in that they're very simple. They're RNA, there are some buffering salts, which you get in all your food, and then there are some lipids, which are essentially fat molecules. And the other incredibly great thing about them is they're very easy to modify compared to traditional vaccines. So you hear about variants of COVID coming along. Some of them might be more infectious, but less virulent. Some of them might be more virulent, but less infectious. It is very easy to change RNA vaccines. It can be done on the fly. And so all we need is to keep up that public and political support of the people who monitor these viruses, who sequence them, who can change these vaccines if necessary. And someday we might have a vaccine that contains RNAs for 2 or 3 or 4 different variants of a protein to cover all the bases, or perhaps certain vaccine will be used in one region of the world where a certain strain is, more prevalent. But that is a fantastic attribute to RNA vaccines. So they're incredibly safe, they're incredibly effective, and they're incredibly easy to modify. One of the downsides is that they're unstable. RNA is very difficult to keep stable, and that's why they have to be kept cold. And that was another part of why they hadn't really been brought to market yet. The cold chain to keep them cold had to be done and had to be put in place and funded, et cetera. So with regards to safety, incredibly safe. Certainly there's going to be some allergic reactions. If you introduce anything, any medicine, any food, any chemical in clothing, any vaccine to hundreds of thousands, to millions of people, you're going to have some people who have allergic reaction. That is fully expected. And some of the studies will show side effects just as high in people receiving placebo as the vaccine. So that is nothing unexpected, nothing that really, luckily treating allergic reactions we know how to do that. And everybody giving vaccines has on hand things to treat severe allergic reactions should they happen. And they will be rare, but they will happen. And that would happen, again, with any new introduction of anything we're putting on or in our bodies. And that's nothing special to an RNA vaccine. I think I covered most of the things I wanted to say there. But it's truly an exciting time, I think, because I think vaccinology has just taken a huge leap forward. And these vaccines, they're going to be safe because there's no virus involved. It's literally just the coding material to make a protein. There's no risk of getting the infection from these. So they're going to be safe in people with bad immune systems. They're going to be safe in virtually every population you can think of. We just need time to study those because those special groups are not generally studied right up front when something's being studied brand new. But I think as data comes in, we'll find that they're going to be safe in everybody. We don't give live vaccines to people with immunosuppression because that's a live virus. This is not. And so I think they're going to be really safe in virtually every population. Now, if your immune system isn't great, you may not make that robust response. So maybe the vaccine won't work quite as well, but that's not a reason not to take it because it's still going to give you partial protection, and it might mean the difference between a mild infection and a life-threatening infection. So, and before I leave, there was one thing I wanted to mention because this has come up. So the benefits of a vaccine, they prevent you from getting sick. If they work perfectly, when you're exposed to the virus, it gets shut down immediately. There's no viral replication, you don't get sick, you're not making new virus, and so therefore you're not shedding new virus, right? So part of what a vaccine does, part of herd immunity is making it such that people do not pass a disease on. So not only do you not get sick, you haven't really been infected, so you're not going to make virus and pass that on. Now, you could have a mild form of the disease and maybe shed a little bit of virus, but that's certainly better than shedding gobs and gobs of virus. So that is also a benefit of the vaccine for the population as a whole. And I think I'm going to leave it there. If some other specific questions come up, I'm happy to chime in again.
Great. Thank you, Dr. Cannon. That was a really great overview. Now I'd like to introduce Dr. Nick Torney, who's an infectious disease clinical pharmacist with Munson Healthcare. Dr. Torney, you've been with us before, and you initially gave us a great overview of some of the safety and efficacy of the vaccines. Can you give us some more detail today about anything new you know, and specifically what types of side effects we may be seeing as we're vaccinating our healthcare population?
Sure, thank you, Diane. Vaccines are generally safe. In the data that we have, the information that we have for the current RNA vaccines is no different. We have data on over 75,000 patients that have been randomized to receive either the vaccine or placebo, and the information from those studies is extremely promising. The common adverse reactions are mainly local, sore arm or pain at the injection site, swelling at the injection site, as well as possibly fatigue, headache, nausea, or fever. And those studies have shown that the second dose does tend to be a little bit more common when it comes to those reactions. This is really no different than many of the other vaccines that are currently on the market. A lot of you have received vaccines like the Shingrix vaccine against shingles, which actually reports higher reaction rates compared to the two mRNA COVID-19 vaccines. There are a couple concerns that I've heard mentioned regarding longer term side effects. And I just want to point out and have everyone think about this. Think about, you, your family, your friends, and the hundreds of vaccines that have been administered to you and your inner circle throughout the years, and thinking about the long-term side effects of those vaccines. There really aren't any that we are aware of, especially beyond the 2-month time frame. And just to give you guys a little bit of comfort there, the vaccines that have been studied to date, being the Pfizer vaccine and the Moderna vaccine, half of the population has had at least a 2-month follow-up for both of those vaccines, meaning the confidence of the FDA and the advisory committee is very high when it comes to knowing the long-term side effects, this long-term side effect profile of these vaccines. The severe reaction rates between placebo and between the COVID-19 vaccines have been similar, and we do not anticipate a large amount of serious long-term side effects from these vaccines. Another thing that came up is infertility. So there has been a claim that a previously employed doctor at Pfizer, that the Pfizer's vaccine causes female sterilization. The origins of this claim really stem from the similarity between the SARS-CoV-2, the virus that causes COVID-19, between its spike protein, which is the mRNA vaccine encodes for that protein, and a protein that is vital for the formulation of the placenta. So the reported risk is that the body mounts an immune response to the spike protein as well as that protein that's on the placenta, and that in turn would cause infertility in women. However, only two very small parts of the protein look similar, and it's not the entire protein that is claimed to be similar there. And in addition, if this were true, then COVID-19 infection should cause infertility, since active infection produces the same antibody response to the spike protein. And at this point in time, scientists have not made that association between infertility in patients that have had COVID-19 infection or the receipt of these mRNA vaccines. And of course, we will be closely following and monitoring this. So those are the main points that I wanted to bring up, and I'm happy to answer any further questions.
Great, thank you, Dr. Torney. I'd like to, at this time, bring Dr. Nefsi, Dr. Cannon, and Dr. Torney all as our panelists for our Q&A session. And the first question is for Dr. Nefsi. The question is related to the stat you reported about 51% of employees and credential providers being vaccinated at this time. Does that mean that 49% have actually declined the vaccination, or is that a matter of logistics right now?
It's probably a little bit of both. There's wide variability when we look at subgroups of the vaccine. Many of our support service people who are working from home and that kind of thing have declined getting the vaccine so that they can leave it for other people who are working the front line. We certainly have, certain segments of the population, maybe our pregnant or breastfeeding women that, might be a little bit more hesitant to take it. And there's the logistical part. I think there were a couple of questions in there about, how much we're offering. And, one of the logistical considerations for this is, we are scheduling people for the vaccine when we know we are getting vaccine. And so, we had an initial surge, and the stats that we were reporting were both scheduled and vaccinated folks. And so we've kind of caught up on those scheduled people and now are starting our second dose phase and have slowed down the first dose phase. So there's a couple of things that weigh into those numbers.
Great, thank you, Dr. Nefsi. Next question is for Dr. Cannon. Wondering if you can talk a little bit more about mRNA vaccines. What does the M stand for? And you mentioned the sort of the history of them being around for decades. Do we expect that we're going to see more RNA type vaccines in the future?
Okay, so sure, that's a good question. So basically the central dogma of biology is that DNA gets turned into RNA, which gets turned into protein. And so this is going on in our cells all the time. Basically any complicated form of life, this is how proteins are made. And when we're infected with a virus has evolved to do pretty much one thing, and that's inject all of its RNA into our cells, or its DNA, if it's a DNA virus. Then once in our cells are essentially hijacked and start doing the work of the virus and start making viral proteins. It can be a couple dozen, it can be many dozens, it depends on the size of the virus, what type of virus it is. And then those new viral particles are assembled like Legos from those viral proteins. Some of those proteins are structural. Some of them serve a function, they're enzymes and other things. Basically, out come your cell bursts open and out come a bunch of brand new baby viruses, which then each go on to infect a new cell. And that's how a viral replication happens. But that, DNA to RNA to protein is, like I said, it's called the central dogma. That's how life works. Messenger RNA is, once RNA is made, it's usually in a big long strand, and then it has to be processed. It has to be chopped up into smaller bits. A cap has to be put on one end, a tail on the other end. That stabilizes it. That makes sure enzymes can recognize it so that protein can be made. There's a lot of chemistry involved. And so messenger RNA is that final product, a shorter bit of RNA that's been modified, ready to make protein. And then along comes ribosomes and other things that use that as a blueprint to make proteins. And proteins, remember, are like a boxcar. Proteins, imagine a train of boxcars. So proteins are made of amino acids. And there's only so many amino acids, 20 or something, and you can make them in a million combinations. Proteins can be long, they can be short, different compositions of different amino acids. And that's how we get all the different proteins that our lives, our cell function depends on. And so that messenger RNA is that final blueprint, ready to go, ready to be translated. It's called into proteins. And so with an RNA vaccine, rather than our cells generating lots and lots of viral proteins from lots of different messenger RNAs, a vaccine like this, in this case, one single mRNA species, it's called, is in the vaccine. So we'll make just that one viral protein instead of dozens and dozens of viral proteins. Now, I do foresee that some vaccines may contain more than one messenger RNA. I don't think there's theoretically a reason why that couldn't happen. And if there were a couple different variants in a population, that's a sort of tweaking of the vaccine that will be done as we go forward, should be done. I have full expectation that will be done. Modifications will be necessary, but that's the beauty of these vaccines, is that to make that sequence of mRNA is something that's been done in microbiology laboratories for decades. That in and of itself is not magic. That's a very well established process. And so that sequence of RNA or that messenger RNA can be changed very quickly. Things like how to have it processed, what sort of lipids to have it with to make sure the cell takes up a little better. These have been studied for years and years and years. And just because we have this great vaccine doesn't mean, we're done. This vaccine potentially could be improved upon in ways. We'll learn lessons from this to apply to other vaccines. And expressing a protein, in this case, it's to get our immune system to be jump-started. But expressing a missing protein in a certain cell population, that has implications that go way beyond infectious diseases. Literally every medical field could benefit in some way from reestablishing a protein that's absent or providing a healthy copy of a protein that's mutated in a certain disease state. There's an endless number of possibilities that you could do with this technology. And it's very elegant, it's very safe, and it was just a matter of having the money and the political will to just get it done. Companies were not willing to spend billions of dollars to make a vaccine unless they knew, it was in their interest. And so it was made clear, this is in your interest. This is in the world's interest, so therefore it's in your interest, and it was done. And I think it's going to be, as I said before, I think it's really, it's kind of about time. It's about time we have this technology that's actually usable, because the idea has been there forever, and it's elegant, and it's just fantastic. And it's going to change the face of vaccinology as well as other fields of medicine.
Great, thank you, Dr. Cannon. I can tell how excited you are about it. It's great to hear. Dr. Torney, there's one question for you. Dr. Nefsi had mentioned that we were just starting to begin to administer the second doses within our healthcare population. Are we expecting that there will be more side effects that will surface as the second doses are administered?
Yeah, it's a great question, and we can anticipate that the percentage of people that have a reaction after the second dose will be higher. That's what we have seen in the studies to date for both Pfizer and Moderna. However, the number of severe reactions really is not much higher. It's just really those, local and systemic reactions that I had described, being pain at the injection site, nausea, fever, just a feeling of unwell or malaise. Those have been reported as being more prevalent after the second dose. It is worth noting, Dr. Cannon did mention that anaphylaxis is something that can happen after introducing a new chemical into the body, and that is no different with these vaccines. If someone did have a severe allergic reaction to the first dose, the CDC does recommend to not receive the second dose.
Great, thank you. The next question is for Dr. Nefsi. There seems to be a nationwide concern with the pace of vaccine distribution. What have we seen locally and regionally, and do you feel that the supply is adequate and that the pace of distribution is as expected?
Those are all good questions. I think, part of the challenge during this whole pandemic is that, many decisions, whether it's about, mask mandates or isolation or shutting down pieces of the economy, and now the vaccine distribution has really been left to the state level. And so, the states are trying to manage as best they can, the distribution and allocation of this vaccine. And so what we're seeing is a difference between how certain states are doing it. So in Florida, for instance, they're saying, we've got vaccine line up, and once the vaccine's used up, we're going to turn you away. We have opted not to do that in this state. And, we have followed both, the ACIP and the health department and the CDC's guidelines about getting healthcare workers and long-term care facilities first, and then moving on to that second tier. I think one of the challenges that we, as well as the state, are dealing with is knowing how much vaccine we'll get. And again, that allocation is from the federal level, from the CDC. And so this isn't, like a drive-through flu shot kind of vaccine. We have to schedule the second dose. We want to monitor these people for 15 minutes. There's a lot of different nuance with the distribution of this vaccine than when we see typical vaccines. And so, that scheduling piece is difficult when we don't know how much vaccine we're getting. And so there's a little bit of a dance of, okay, we think we're going to get this, and so we're going to schedule these people, and then we're going to, take that next step. So that's really the balance we're trying to figure out. I'd say overall, our vaccine clinics have been running exceedingly well. They're incredibly efficient. People are getting in and out very, very quickly. We hope to continue to work with the health departments to bring that structure and process out more broadly to our community. And as we receive more vaccine, we'll expand the access to that vaccine.
Thank you, Dr. Nefsi. One more question for you, just a clarification on the different tiers. Where do dialysis patients fit into this grouping?
Yeah, the dialysis patients themselves, it looks like, would be in tier 1C unless they were over the age of 75. This is just one of those things as we continue to try to make a decision. There's lots of reasons, oncology patients, dialysis patients, a lot of our high-risk patients that, many would feel deserve to be in a higher tier. We're really just trying to address that balance. And what we'd like to do is, I think Dr. Torney made the call a while ago that this isn't about people getting vaccines. This is about a vaccination program. This is about getting the broad number of people in our population vaccinated against this vaccine, and that's how we're going to get past this. So I would say, yes, they are in the first tier. When I read the guidelines, they would be in tier 1C. And so we would put our, patients over 75 ahead of them. But certainly you could make the argument that they are at risk.
Great, thank you. The next question is for Dr. Cannon. There have been a lot of media reports about what's happening in the UK around the mutation of this virus. Can you speak to what we know about that? And specifically, there's two questions. One is related to, will the vaccine still be effective against mutations? And you mentioned how quickly we can adjust mRNA vaccines. But then also, I'd like someone to speak to whether or not there will be different treatment protocols if someone's hospitalized because of one of these mutations. So Dr. Cannon, let's start with you first with just, will the vaccine still be effective?
Right, so coronaviruses mutate. They're not the fastest mutating of viruses, but they do mutate. They're not as fast as flu and some other things. But mutations as a virus moves through a big population are absolutely expected. Sometimes these mutations increase the transmissibility of a virus. So the virus is evolving, a certain portion of the virus may branch off to evolve to be more infectious, but that often is accompanied by being less virulent because it's sort of a trade-off in what's called fitness. Sometimes that doesn't happen. Sometimes it's more infectious and still just as deadly. But those are the sorts of things that will require constant monitoring by virologists in the public sphere and in academia and even in the private sphere, which is why we have to keep our eye on the ball in this for forever, essentially, and make sure that there's sufficient funding and will, political and public will, to keep monitoring these variants. If a virus mutates enough in just the right spot, yes, it is theoretically possible that a vaccine would stop working. But again, that's the elegance of RNA vaccines, is as long as we know about it, as long as we continue to monitor it, vaccines can be rapidly adjusted. And so I wouldn't be surprised, as I say, if there's a if there'll be variants of the vaccine, perhaps to be given in different regions of the world, depending on what virus is circulating, or that maybe it's even changed annually, like we do with the flu vaccine. Or perhaps instead of one species of RNA, there might be 2 or 3 for the most prevalent mutations out there. As far as we know right now, that's not necessary. It's not impossible. Eventually that could happen. That would not be unexpected. But I think as far as the data we have so far is that this one from the UK seems to be more highly transmissible. There's a 0.7 uptick in its R value. R value is the number of people that you infect when you yourself get infected. And so something like measles has an R value of like 15. It just goes through, like wildfire. Something like this has an R value down in the sort of 2 range where a couple other people will get infected. But 0.7 is significant. That means for every 10 people, several more, 4 or something, 4 to 6 or something, will get infected. So I mean, it's a big deal. Hopefully it's not also more virulent, because that would be a setback. But those are exactly the sort of data that take time to accumulate and to respond to, and that's why virologists and ID docs and public health officials got to keep their eye on the ball. And the vaccine may be changed, and there may be various variants of the vaccine. So, I mean, I guess I'll leave it there. It's not unexpected. We can adapt as long as we keep our heads down. Currently, we don't have any evidence that this vaccine will not work for these variants. It might turn out that it's less effective. Well, we'll have to see, but currently there's no evidence. And it's certainly not a reason to not take a vaccine, because if it is proven to be completely ineffective for a particular variant, well, a new vaccine will be engineered for that particular variant. But in the meantime, without knowing that further, without time, the vaccine should still be given as planned.
Great, thank you, Dr. Cannon. And Dr. Nefsi, just any word on any treatment protocols that may have to be different if this virus mutates more?
Yeah, not at this point. Like Dr. Cannon said, we do expect variation as these viruses go through the population. Many of the treatments we have, like the dexamethasone, really are less about the virus and more about, managing the symptoms and some of the side effects. So we don't anticipate right now any changes in our treatment protocols, but obviously we will continue to monitor, as we hear things from other places that are seeing these variants.
Thank you. Dr. Nefsi, one more question before I leave you. Related to what is Munson Healthcare doing to try to ensure that our healthcare workers do get vaccinated? How are we communicating with them? And are these numbers, the rates that we're reporting amongst our own healthcare population, typical of what we're seeing across the country as well?
Yeah, it's a great question. And I would say, our employees are a reflection of the general community. And so, we have some areas among our providers, as an example, or some of our folks that have worked on these COVID units who have a very high rate of vaccine adoption. I think these are the employees and folks that are seeing the effects of COVID-19 on a day-to-day basis. And they are signing up and getting vaccinated. We have others, who are a little more wary and have the same questions that, you're asking here. So we're trying to do the same thing. We've provided, some webinars and support with some of these same people to our clinicians and providers, as well as our staff, trying to address some of the questions. One of the things we've been dealing throughout this pandemic is, a certain level of misinformation. I call it sort of the second front of our war on COVID-19. I mean, there's the virus itself, and then there's a whole nother piece of misinformation that we've been trying to manage. And, the vaccine rollout has been no different, where there are people who have valid concerns, and then there are people who have concerns that are maybe less so from a scientific perspective. And so, like we said, our employees are a reflection of the communities and our population as a whole. And so, some people just are sort of sitting back and waiting to hear. We've certainly received very positive feedback from the webinars we have done, appreciating to have some of this information and explanation that maybe isn't as obvious when you're reading a news story from something. So we are going to continue to try to educate our providers and staff, encourage them to get the vaccine, and continue to share data on the safety and efficacy.
Great, thank you, Dr. Nefsi. Dr. Cannon, question about how long immunity will last. So there's two parts to this question. One is, if you receive the vaccine, do we know how long the immunity will last? And secondly, if someone has already had COVID-19, doesn't their body already have natural antibodies that will protect them for a period of time, and should they not be vaccinated?
Right, those are good questions. So it appears that immunity to natural infection although antibody levels do fall over a few months, it doesn't take much to protect against the new infection. So initially the reports, oh, antibody levels fall, oh no, everyone's gonna just keep getting this over and over again, and we're not mounting a good natural immunity to this. And certainly it's unlikely to be lifelong immunity like it is with some infections, with chickenpox virus and such. But it does appear that because there's cell-mediated immunity involved, which is hard to measure, actually very hard, really you have to have a special research lab sort of measure that type of immunity. Just measuring antibody levels, they fall, but that's not a very good measure of your overall immunity to something. So it does turn out that at least 6 months, if not longer, immunity is likely through natural infection. I suspect they're going to find it's quite a bit longer than that. But those are sort of reports that said that, oh, we're out to kind of verifying that at least 6 months out. The vaccine, we're several months out, and immunity seems to be at least, will last at least several months. I'm hoping it's longer. But again, we have to just wait and see. And it's not a reason not to get the vaccine, because even if you could be immune for a few months, if we were all immune for a few months, there's no food for the virus, it dies out. I mean, this is how pandemics end, is that there's not enough host available. So either a population gets spread out, or in the Middle Ages, enough of them died so that there was not a concentrated population anymore, and the organism couldn't stay in circulation. It couldn't jump from host to host because all the hosts were dead. We have some degree of herd immunity to some viruses, to some infections, but that's with the help of vaccines. We have never, as a population, got to sufficient herd immunity just on our own for an emerging infection. That's never happened. We need the help of a vaccine to get that immunity. And so even if the vaccine doesn't last lifelong, that does not mean it isn't doing its job and that we can't, get this thing under control. But it might mean we need a coronavirus vaccine every year like we get a flu vaccine. So as far as how long immunity lasts, studies are out. It's favorable. The data on natural infection is more favorable than it used to be. It's getting longer. It's clear that people are infected. Now, should people who have had natural infection get vaccinated? Excellent question. Hey, it would say vaccine if we didn't, The problem is we don't have enough data to quantify the difference between the vaccine-induced immune response and the natural immune response. People assume, oh, it's a natural immunity, it's going to be better than a vaccine. Not necessarily. You have one protein expressed at high levels and your immune system concentrating on that. Perhaps that actually turns out to be better than having an immune system focused on several different viral antibodies. So just to make that assumption, I think is jumping the gun. Maybe someday with more data, we'll say, look, if you have well-documented immune response, you still have good detectable levels of antibody, let's say, something that we can measure and quantify, then we might say, you don't need a vaccine. But I think that's unlikely because the virus is going to change as it goes through the population we've already talked about. Immunity is going to wane anyway. So I think it's unlikely that we're going to get to a point where we check someone's immunity before we give them a vaccine. I don't predict that happening. I could be wrong. And I also, which is another reason why having a sort of log, if you've had a vaccine or had an infection, sort of viral passport, to me is a recipe for disaster. But that's a whole other topic I don't think we need to discuss here. But there's a lot of reasons to me why that wouldn't work very well either, some of which relate to what we just talked about.
Great, thank you, Dr. Cannon. We have time for probably 2 more questions, and this next one is for Dr. Torney. Could you speak to the age groups? What is the youngest age the vaccine can be given to? And I know there's a difference between Pfizer and Moderna.
Yeah, so the age at which the vaccines can be safely given depends on the age in which they have been studied, and there's confidence that the vaccine is safe and effective in that population. And for the Pfizer vaccine, that age is 16 years old and up. For the Moderna vaccine, that's 18 years old and older. And the rationale there is that there were enough patients in that age group in the large phase 3 trials to give the FDA confidence to use or to have the age range down to 16 for Pfizer and 18 for Moderna. I will comment that there's definitely ongoing studies in that population, because of course we want to vaccinate that population, especially those with pre-existing conditions in our pediatric patients. But at this time, the emergency use authorization is for those specific age ranges that I mentioned.
Okay, great, thank you. And before we take our last question here, we are getting a lot of questions into our Q&A panel here. We're not going to be able to address all of them today, but some of the questions that are being asked, those answers are available on our website, munsonhealthcare.org. And there's an FAQ section in our COVID-19 area that does address some of these answers. And if we weren't able to get to your question today, we will be looking through the questions asked and adding additional answers to our FAQ section. But to kind of close us out, Dr. Nefsi, we're getting continuing to get a lot of questions about when can I get vaccinated? Is there a list I can get pre-registered for? When will vaccination start for age group 75 and above? And basically, what are the logistics around that? Who's responsible for, is it the health department's responsibility? Is it Munson Healthcare? So can you just once again kind of wrap it up and address that we are still in tier 1A right now, and where we're at with that?
Yeah, thank you. We are still in tier 1A, and like I mentioned earlier, starting our second doses today. But to kind of start with your last question there, Diane, I would say it is everybody's responsibility who is receiving vaccine to get that vaccine out to our general population. So whether you're the health department, your CVS, or your Munson Healthcare, we all collectively, I think, feel very strongly that it is our responsibility to get that vaccine out. What that looks like and how we do it is really the next question. So I think as we finish with the tier 1A, there are a lot of conversations going on with the health departments about how do we get the vaccine out to our patients in the community that are over 75, as well as those other, first identified essential workers. So I would actually expect to have more information on that by our next press conference about what that looks like and how we'll do that. What I can say is that each entity will likely do it a little bit different. So Munson Healthcare might do it a little differently than the health department is, which will be different than potentially CVS and Walgreens will do. But we will all be working collectively to try to get vaccine out as quickly as we can, so that we can get the phrase the state is using, shots in arms. So we can get this vaccination program off and running so that we can start to get to the numbers that Dr. Cannon referred to that we need for herd immunity. So we have a collective responsibility, and we will continue to try to get information out either through this press conference or on our website, through the health department and their website, through our media contacts. Any way we can, we will get that information out. There is no magic list. Nobody is on there. I know that many of our primary care providers have started in preparation, looking at who their high-risk patients are, who their older patients are, so that when we are ready to start that distribution, they kind of have it ready. But I would just continue to ask people to be patient. We are working on those logistics as we finish up our initial tier 1A, and we expect to have more information about that coming up soon.
Great. Thank you, Dr. Nefsi, and thank you, Dr. Cannon and Dr. Torney, for joining us today. Again, we will be looking at these questions and continuing to update our FAQ section on our website, and we look forward to seeing you next week, same day, same time, for another update. Thanks, everyone, and have a great day.